Okay, so what we want to try to do now is attempt to synthesize big picture messages that came out of this, partly by looking at sort of where the groups overlapped in what they saw, where they differed, and so on. Now, we only have 45 minutes for this, and I'm sure none of the groups had enough time for the exercise in the first place, so we can't triple that and have the same 3 conversations over. So we're going to kind of telegraph it. But let's just hear very briefly from each of you how you construed the treatment theory for this study. We can start with Mary.
I will try my best to organize.
We thought that there were elements of a treatment theory, a conceptual theoretical model described, but that ultimately the specific theory of action for the proposed intervention was not well explicated, and that at some level that influenced our ability to answer all the rest of the questions.
Okay, Marcel?
We didn't address that into any detail other than a meta-observation that underlied the treatment, which is the assumption that social communication skills are trainable, which, if it's true, people would assume that you need many more hours of training than was provided in this study.
Okay, and Jules?
I think our group would agree with Mary's group to a large measure. On the face of things, it looked like they had a manual, and they were trying to prove whether their manual worked or not, basically. And they never really laid out an explicit theory of why the treatment manual should work. The other thing that we thought was that, and got a little bit derailed on, I think perhaps, was that the intervention was really directed at a task and not an impairment. In other words, the task that they were trying to do was to improve social communication. So the cause and effect between their intervention and a specific impairment was not really clear, because there are multiple impairments that were impacting the task.
Okay, so the other thing that I think our group also talked about was that there was a goal-setting piece of the intervention that might have a different theory about something motivational versus this. We agreed that it was a practice-oriented, skill-oriented thing, but as Jules said, didn't seem like they would predict that some underlying impairment would be fixed across the board. It was the ability to perform a social communication task despite God knows what impairments are there, because it's not focused that way, right? Okay. What did you think the next broad purpose of research? Where should we be going? What should we be trying to accomplish? And maybe we'll start on this end.
Well, the first, I guess there are a lot of levels to this, but on one level, the first thing would be whether this is an effect isolated to the Craig Institute, or whether other people can actually accomplish the same thing given the manual. So we'd like to see it replicated at different sites. The second thing is that in the intervention itself, there were actually a number of specific interventions that could be parsed out. And for example, the goal setting was one, feedback and practicing were 3 of them that we came up with. So which one of those is really the active ingredient, and are they all interactive and they all need to be present for the outcome to exist? Or is, for example, the goal setting really the active ingredient and the only thing that's going to make a difference. The third thing I think is that we really had no, and we got into this in another question, but I'll mention it now. We really don't have any way of evaluating whether all of the interventions were delivered the same way or not. Assuming it was one person doing everything one time, then we could say that the intervention was uniformly applied. But if it was more than one person or more than one sitting, that might not be the case.
Great, thanks. Marcel?
We were schizophrenic about this, with some of us thinking that this was a premature RCT, that there was not sufficient underlying science to demonstrate that, say, goal setting has an effect, or that role playing has an effect, etc., while others were willing to build off what Dahlberg and others et al. Have shown, and we're suggesting the next phase could either be a less purified sample, pick up all the people with comorbidities that they didn't use, work on specifying the optimal dose by comparing different duration of treatments, and I lost the third one, and when it comes back to me, I will report it.
Okay. Mary?
Just to add a few other suggestions from our group, one suggestion was to use different analytic techniques to go back and look at the data a little bit differently, to include effect size and so forth, rather than, this is not my strength, and I would look to Allison, but that they could maybe look at the data a little bit differently that might inform another project. One of the other things we talked about was, again, maybe they could take their preliminary results and go back and think about what were the specific mechanisms of action that seemed to be important. And we went back and forth and talked about this a lot in our group. Was that mechanism self-efficacy? Was it skills? And then do another study that would both specify that with more detail and then study it with more specificity. We were also suggesting that anything that further looks at the durability of the effect would also be very helpful.
Okay. So let me just point out a couple things here. So one is, I mean, in our group and maybe in all the groups, there was this tension between showing that a thing that seems to work one place works more broadly, either in more facilities or for broader samples of patients. That, at least arguably, requires kind of freezing the intervention in this form and then asking that other question. And then there's the flip side. Are we sure that this is the best intervention that we can get to? And is this the one we want to test broadly? Or should we be focusing on making this intervention better or more powerful, which might involve understanding which of the ingredients are delivering the most power, whether different ingredients deliver different pieces of it. So where I see that, like I didn't go into this, but if it turned out that there was a pattern in which of those many sub-functions benefited significantly versus less significantly, that might give you a hint that it's more about the role playing or more about it probably wouldn't prove it, but it might generate some hypotheses that would then have you say, you know, I think the thing we should beef up is this before we freeze it into our next iteration of the manual. Somebody said about effect size too. I mean, the other thing in our group talked about is if the effect size is whopping and we can afford this intervention, how desperate are we to make it better, versus if the effect size is kind of borderline and it's really expensive, that would probably push us in the direction of refinement and strengthening before going to broader replication or dissemination. So these are both things probably need to happen. It's more of a question of sequence and priority and where to spend resources and stuff like that. So, okay. In terms of patient characteristics or inclusion criteria, how did you think that the next wave of research should use the same criteria? How would you change things, Marcel?
The criticism in the group was not so much in the next expansion as maybe in redoing it with a better characterization of A, what were the specific social communication deficits in the various members of these groups, and B, to the degree that they expected that by enablement theory, social participation would magically improve, a better characterization than CIQ and CHART together can do of the social participation deficits in these people. And then, another thing which may not be selection, as well, mediating factors and better measuring those, like social support. And that ties in with a comment that was uttered in our group, that this study really is very unclear as to exactly what the role was of those family members.
Okay. Well, let's hear from others first, and then I'll make, George?
Just a couple things in addition. There we go. Number one is we've already said, we thought that the group should probably be broadened to allow to test for covariates among the characteristics of the group. This group was unique in a couple ways that might not be generalizable. Number one was the fact that 80% of the group had college education, which might not be generalizable to the TBI population writ large. And the second was that a certain amount of intact memory was required, just as a given here, because you had to be able to remember the feedback in order for the hypothesis to even be applicable. So these people had intact memory, were probably better educated.
Okay, Marcel?
I just want to comment that as academics, we of course like to point out that education is relevant to social communication, but what's the proof for that?
So I just sort of separated this crudely into possible changes in inclusion and exclusion criteria versus covariates that we want to have on the people we include for analysis, because those are two different issues, right? So I think several of you said we want to broaden the heterogeneity in some sense, make it more like garden variety TBI patients we are likely to encounter. But we do have to ask, broaden in what way? So do you want to broaden to a person who's aphasic? Do you want to broaden to a person who's has behavior problems and doesn't want to interact with other people? So you have to think about the broadening that would be sort of preposterous given how you think the treatment works versus the broadening that will make it a more representative patient population who could still plausibly benefit from the treatment. So that's where knowing more about the specific communication problems, maybe it doesn't help everything, but it helps people who have this kind of, who are too talkative, but not people who have nothing to say, blah, blah, blah. Maybe, now this is going to get into the outcomes measurement, but maybe having some measures of actual community participation that could look at whether the communication improvement begins to take you out in the community more. And then social support, which actually I guess could be either or both a mediator of treatment effects because they help you with it, and also you might garner more social support if you don't alienate everyone in your social life, so et cetera. So, okay. comparison treatment or treatments. What if we're going on to the next step in our program of research? What do we want to compare this treatment to? Mary, let's start with you again.
I'd like to point out that I've watched all the presidential debates, and they take the opportunity to answer their own question, even though they're asked something different. And I didn't get a chance to speak to the last question, so I thought I would just add my response now, which was just to say that.
Did I skip you?
You
sorry.
skipped
I'm
me.
sorry.
That's okay. I'm just
I
joshing.
lost track of my.
I'm just joshing.
I was doing Latin squares.
That's
and
okay.
I got confused. Yeah.
No, I honestly didn't have all that much to add, other than I think that, when it gets down to looking at the clinical utility of these interventions, it really, in part, has to do with offering what to whom. And I think that even with this study, there were questions about the severity of the actual TBI, given that they were using discharge or enrollment in an inpatient rehabilitation program as a proxy for moderate to severe TBI. So that might be something to look at. So back to the question, which had to do with comparative studies. I think that was what you asked us to speak to.
What comparison or control condition for your next study would be?
Oh, we didn't really talk about that so much, but again, we got back to always revisiting this question of the theory of action, which would dictate what you would then use as a comparison intervention in the future based on how you were specifying that. So, for example, we circled back frequently to questions about skill versus self-efficacy, and, for example, if self-efficacy was central to the intervention, might you just address self-efficacy separate from speech and communication?
Gotcha. Okay. Marcel?
You're a good politica. Not only doesn't she answer a question that wasn't asked, and then she repeat the same answer because whatever.
She's good.
Yeah, she's good. The basic issue with this study was that there was a weightless control group, so there needs to be a real control group for, at the minimum, the social interaction that these people got from it. So the comparison group should be, an attention control / social interaction, social group.
Okay. Jules?
We didn't, well, as we said before, we think that the treatment needs to be decomposed into its multiple components, and those should probably be tested individually and compared to this treatment to see whether any of them individually equal the result of the whole. On the issue of comparators, we did have some discussion about what an appropriate comparison group was. The wait list control, we actually, I think, probably came away thinking that it wasn't, certainly wasn't a deal breaker in this study. But the notion of whether the control group would even have to be a comparable or a remotely comparable intervention, or whether we could try a placebo. This is where we talked about giving them a sugar pill, the smart pill, as a control, and seeing whether that would have any difference. I guess the bottom line was we thought that we didn't have to come up with some sort of sham therapeutic intervention. We could come up with, we might be able to come up with something else.
Okay, so this is a really interesting dilemma, and Barbara, you'll remember us talking about this general thing a lot, because one thing that happened in our IOM committee was, I think because people are delivering service to people in need, there's not a big desire to deliver nothing to people. And so people move quickly into comparison of treatment A versus treatment B. hoping that treatment A isn't as good as treatment B, and then you get no difference, and then am I sure that they're both useless, or could it be that they're both useful, right? This was the dilemma. And the problem is when we don't have a very clear specification of the active ingredients, it's difficult to be extremely certain that you don't have any. And so I guess I worry when you say, well, let's have a control for social interaction, but this is a treatment for social interaction. So an efficacy or effectiveness study with social interaction as the control seems risky. Now, if we want to say, does goal setting convey the power, then we can have one with goal setting and social interaction and one with social interaction. But that's trying to answer a question about the specific ingredient or specific power of one of the ingredients versus others. But I worry about thinking about a big package that involves social activity as a placebo. Do you want to add anything to that, Barbara?
I think you articulated it well. I was sitting here, I was thinking, I was wondering, well, I guess if you knew the real standard that all people who need this is there is something that they get, and you thought that you had enough evidence from this one, we talked about this proof of principle study. Some people might say we still want another study, larger, still with perhaps a waitlist control. I mean, those are the issues, the key issues to debate. But at some point, yes, you'd want to compare it to what would be standard of usual care, unless only a small fraction of people get that usual care. So that turns into a pragmatic piece, but that may be a little farther down the line.
I think in the real world right now, standard of care isn't too far from the waitlist control, unfortunately. So, yeah, Thea?
So, John, in this case, if you have a social interaction control group, wouldn't you have pre-specified active ingredients for your active social interaction group so that you can compare it to a social interaction group that is not treatment? In other words, if they're both equivalent in social interaction activities and gender social interaction skills, wouldn't it be more cost-effective to send somebody, let's say, to a meetup group to do that instead of expensive treatment?
Well, yes, indeed. If you had a lightweight treatment and a heavyweight treatment, and you knew that one of them was effective, and then they didn't differ from each other, that'd be great, because you'd say, well, let's do the cheaper one. The problem is, if you're not sure that either one of them does anything and they don't differ, they're both useful or they're both useless. And that's the predicament, because the question is, do you feel like you are confident that this treatment as currently manualized works? And now we can start saying, well, what if you take this out or that out? What does this piece do? But if you're wrong about that, and an example that came up also that's maybe a little less intuitive is we looked at a study where memory remediation and attention remediation were being compared on the assumption that one treatment would benefit one thing and one treatment would benefit the other thing. Problem is, how do you work on memory remediation without paying attention, right? And indeed, the memory group seemed to improve in attention and memory, and then you say, well, does that mean that was just spontaneous recovery, or does that mean that those ingredients had effects on attention that were not predicted? Right?
Yeah, if you're satisfied with the effect size of this treatment, then there's no reason to break out the treatments into more specific components and do a social control. If you're not satisfied with the effect size that you have now, then you've got to improve your treatment, and you're not going to do that without breaking it out.
Right, and Dara?
Right, and I think the issue of, again, this was a beautiful small trial in one setting. What if those two therapists were such dynamic people, they'd been working with this for 10 years, and how well can you disseminate that in other settings? You just don't quite have enough evidence about that piece, but it's a strong proof of principle study.
Right, and the other thing just to say is that what came up in our group, and it is coming up here too, is that these things are not all driven by scientific concerns, right? there's partly a cost issue, right? You might be satisfied with the effect size, but it was really expensive. Now you still want it to be more powerful so you can deliver it less frequently or quicker or something. So those, but if it's cheap enough and effective enough that you're satisfied, you may prioritize replication in its current status. If it's not good enough in some way, you may prioritize making it better in some way. So, okay. Outcome measures. What kind of outcome measures should we use in our next phase of study? Don't all talk at once. Oh, no, I'm calling on you guys. That's right. Jules.
I was hoping that I wouldn't have to talk at once.
Oh, okay.
So I think that clearly the outcome measure that's important here is the rating of the communication skill by the people that matter. We had a lot of discussion about whether the specific instruments that were used here really translated over to improvement of social communications, or whether we were kind of teaching to the test, if you will. But assuming that they are what they are, that was that. The other thing that we had some talk about was the number of outcome measures that would be appropriate for a study, whether multiple measures are appropriate because they in fact each measure different parts of a spectrum, or in the military context, whether that's one of the problems, which is too many outcome measures, and we ought to have, and which can lead to shopping around for the outcome of your choice, or whether we should limit it to one outcome measure, pick one and stay with it. So
Okay.
we didn't come up with we didn't answer that question. We just thought it was a problem.
Marcel?
I think we didn't address this other than in the context of, if you believe the enablement theory that improvement in social communication will lead to better social participation, you need better measures of social participation, and or measures maybe of social communication in community participation settings.
Okay. And Mary?
I think just to add to that, again, I guess the emphasis of the rather small discussion we had in this particular area was the importance, again, of outcome measures that are more distal, that maybe don't rely so much on self-report, or more complex constructs such as satisfaction with life, which is important. I think the other piece that was reflected in the report itself that the IOM generator, your group did, has to do with the need for more objective performance-based measures, and something like that would have been really interesting in a study like this, where the person would have been given us some kind of a more real-life social communication task or activity, and then the performance itself could have been evaluated more objectively.
Okay. Now that, of course, and I know we didn't ask you to look up the measure. That would, of course, assume that we have a validated task that is sensitive to that, and so on and so forth. So it sounds like as you're thinking about moving broader, you logically do want to ask about more practical impact. I guess I would, Dave knows that I'm not in the one outcome measure at this moment in time, because I think it would be risky not to include the outcome measures that they found the primary efficacy in their study. Because what if we don't include those, we do the study, we don't get impact on these outcomes? Did the treatment still do the thing it did for them, but it didn't do the thing that we wanted it to do, i.e. the enablement link was not what we predicted? Or did we have a different patient population, ineffective therapists, blah, 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 and it didn't even replicate the first thing? So I think it's scary to change a bunch of things all at the same time when you're, quote unquote, trying to replicate, because if you succeed, great. If you fail, you don't know what's going on. So, experimental design. How did you want to do your next study or studies? Mary, let's start with you this time.
Okay, get my notes. I don't think that we did. I'm trying to. We pass on that one.
Okay, let me just. Let me just point out to this group that you will be publicly humiliated this second and third time as well, so we hope you will try to answer the question. Marcel?
Depending on your take on this study, yeah, if you say it's premature, yeah, go back to simple pre-post, single subject design, etc. For the people who are willing to take off with this thing, probably an RCT as a next phase, and I don't know to what degree your word design includes such things as, get an active control rather than a weightless control. Get a broader cross-section of participants rather than the comorbidity-free, quote-unquote, section you have here. So.
Okay. And Jules?
We didn't really have anything to add. Sorry. We didn't have a lot new to add on this. I think the sentiment was largely in favor of an RCT as the next step. It needs to be bigger, for one thing. But we did have some discussion about the fact that cost effectiveness applies not only to the treatment, but to the research effort as well. And that depending on the effect size, it may be that an observational study might be more cost effective than an RCT and might be more what we need. It just, it depends.
So, I mean, we came up collectively with a pretty broad range of designs, but I don't think that's as problematic as it looks, in the sense that what I mostly heard was people wanting to answer different questions with different designs, and that's appropriate. So if you said, what I really want to know is if this same intervention works for a lot of people in a lot of places, then you could really use the same design they used, but in more settings. I would say even a waitlist control or a untreated or standard of care control, because you're not asking which ingredients, you're just saying, can I trust the results more broadly? If you get to specific ingredients, then it's probably going to need a more tight design than just implementation and observation of change and so on and so forth. And then the question between, well, the one issue with the efficacy RCT was what that control would be and whether it's an ingredient control or what it's a control for, as well as the cost issue that was raised. So, Rick?
If you were going to change the design of the study and also expand the group, wouldn't you want to do one first before the other instead of doing both at the same time? I mean, you talked a little bit about that. I think you have to do one or the other, or else you're going to get confused, I think, with the results.
Well, I do think it would be risky to broaden the population and compare this to a pretty similar variant at the same time, right? Because then both might work for your new broader population about equally well, and you don't really know what's going on. I think there potentially, you could do an RCT that has a no treatment and two variants, and then both can be compared to the no treatment, but they can also be compared to each other for issues of ingredient, like we talked about. What if it's really mostly the goal setting of what you want to get better at, and you could do a 2-hour goal setting intervention and have 90% of the impact of this 12-week group? That'd be nice to know. I think it's really an issue of practicality and cost, whether that's a third arm of one study or that's yet another step in the sequence. Yeah.
So just one observation I've had about the trials here, which aren't many, but I thought this was a very good one. There hasn't been much use of innovative designs such as factorial designs, and this actually may lend itself to it because these are package types of things, and the question is what happens when you put two packages together? And I just bring that up as something to consider. The other thing is that this field is also fairly devoid of adaptive types of designs, whereby these are long-term, this would provide another long-term thing whereby people could get information in real time and alter a randomization or even a treatment arm based on it. Just a thought.
Thank you. Yeah, so that's especially the first point you made. I mean, potentially we could be answering ingredient questions and efficacy. Part of this also, of course, has to do with sample size and stuff. So to have factorial designs where you have multiple combinations, you know, you're going to need more subjects than you have treatment A and treatment B. No?
Well, actually, you save on sample size of factorial design on the assumption that you do not have an adverse interaction between the two active treatments. You'd have to know that to begin with, but the value of a factorial design is you gain power with less sample size. Synergies are okay. Synergies are okay, but it... Well, usually it's not 10%. You know, usually you allocate it, you know, fairly equally. A quarter here, a quarter here, a quarter gets none. You know.
Marcel?
One small addition wasn't mentioned in connection to this thing, but elsewhere. What this study surely needed is some attention to treatment integrity, and we would want to see that in the next study, presumably.
Yeah, that's a good point. So we talked about especially if our next move is to test this in multiple sites, we need a measure of quality of treatment, provision, delivery of the ingredients, which requires us to say which ingredients did we want to make sure were delivered and stuff like that. So, and I don't think they mention an adherence measure for this, do they?
No, but surprisingly, you can look at treatment adherence or treatment integrity without even knowing what you're delivering, as long as you have a protocolized manual and you make sure people follow the manual. You have no idea why it works, but either it works as delivered or as written, or it doesn't work.
Okay. Yeah, so the last thing that we wanted to try to get to, and to some degree we're going to get to this implicitly by talking about all three studies, but sort of meta lessons that we got from looking at this study, things that we could generalize to other studies of a similar maturity. So do you want to, Jules, do you want to say anything of a more general nature?
Very general. I think that we thought that the issues that arose from this study, the concerns that we had, the trade-offs, et cetera, were probably going to be present in a whole lot of other studies in the cognitive rehab arena. And so the questions that we're asking here and the things we're thinking about are probably going to be present across the board.
So in particular, one of the tensions that I think every group has talked about is this issue between understanding at a finer level where efficacy is coming from, what the ingredients are, really fleshing out the treatment theory, mechanism stuff, versus the more practical generalization, efficacy, effectiveness, impact, which will benefit from early standardization and moving it out, right? So, and how would you, let's just go a little bit farther with that and say, how would you decide, given that those two things are in tension with each other, how are you going to decide at any given moment, I care more about digging into what are the active ingredients, or I care more about demonstrating the generality of the effect. Any thoughts, Barbara?
Think about the first speaker this morning.
Can you just go to the microphone?
You think about what we heard from the first speaker this morning.
The audience. And, you know, I think that when I put that in perspective, then I'm thinking more about building on a base and moving some research forward along the pipeline. And that would mean understanding about generalizability and so forth. And maybe you can build in something along the way that helps you understand better what worked. In care delivery studies, we could do some qualitative work to try to tease apart some of that. We don't have to randomize everything in the world. But anyway, my thoughts are that just thinking about what we heard that set the stage. People are looking for evidence to move forward down the pipeline so they can make decisions. And that's seems like that would weigh into this tension.
Any other thoughts on that topic, Mona?
Yeah, and then the converse of that is when we do like an RCT and it doesn't work, people say that's because you only did 3 hours and it should have been 5. So the two are so intertwined. I don't know the answer, but I think they both need to be considered.
Right, and you know, the weird thing for me is that I feel like to a large degree they get decided, or maybe they should, if you will, get decided more on almost political grounds than scientific grounds, in the sense that, you know, if I can show that this thing that I don't so much understand has a lot of practical utility, I can get other people to give me money to figure out why and how to improve it and so on and so forth. If I focus on a nuance, it doesn't pan out, and then I say, well, there's another nuance I'd like to focus on and another nuance I'd like to focus on, you know, I'm probably not. So, I mean, I'm not saying it's always in that direction, but I think the reality is if the military had a treatment that came from a manual that was shown to have significant effects in real life, that might not only move that treatment forward, but might move a climate of forward movement forward, if you will. Yeah.
And I think that the other thing you have to sort of, and I only say this because I've been on multiple DoD review panels and VA review panels and many sides and have been a researcher in VA, and so I kind of appreciate this. When you go to these things, part of this too, just generalizability and having something that you could give to a clinician that has some evidence behind it and that you have some general parameters by which to implement. That is clear, concise, and has an effect that we can point to and say this is something to do. And I agree with you. We do a lot of political stuff. No, we do no political stuff. We do nothing that is politically driven.
I mean, a little p.
I'm just saying we've never looked into anything because it's politically driven. Unfortunately, the things that get politically driven are not this. They're not cognitive rehabilitation therapy necessarily. They're other things that people, bright lights, air, pressured air, not pressured air, scented things, you know, whatever. I mean, you can politicize a lot of things. What I'm saying is if you could design good research like this, that you could say this thing works for this thing, and this is how you would do it, that would be really, really useful no matter how you got there.
This is a judgment call, though, because the downside is what Mona said, and I experienced this. The University of Washington did a single-site RCT of a telephone-based intervention that was well done and that had highly significant effects, but we didn't really know how or why it worked. They then got a grant to replicate in 3 sites. We were one of the 3 sites. It didn't replicate not only in our 2 sites, but in the original site, and we have no idea why. So because we thought of, we're just going to replicate it, it'll work great. We didn't have like a bunch of things that we would measure to find out why it didn't replicate and what parts might have done what and so on and so forth. So in that sense, that was just kind of a lost opportunity.
And probably you'd want to build in some way of assessing for that possibility and what it why in a next phase trial. And I totally agree. And I would just say, again, I'm not in this field, so I can kind of like throw out some stuff here. But, I looked